Okay. Good afternoon, everyone. Good afternoon, everyone. It's my pleasure to introduce Dr. Salim Ba'dini. She will be presenting the symposium of AstraZeneca on the Asthma Connect Lebanon National Screening and Referral Program. Dr. Ba'dini is a pulmonary and critical care physician. Dr. Ba'dini is a pulmonary and critical care physician at the Levant Hospital, and she's a very active member of the Pulmonary Society. Good afternoon, Salim. Please, the screen is yours.
Thank you, Dr. Dabar. I'm very happy to be part of this LPS Congress this year. First of all, I want to thank the President of the Congress, Dr. Zeina Aoun, who since the beginning of these 2 years with us, she's been working a lot to the society. In the name of all the pulmonologists, I would thank her. I would also thank AstraZeneca, who's been next to us also all the time. Today, I'm going to present to you the Asthma Connect, which is a study that was led by the Lebanese Pulmonary Society in collaboration with AstraZeneca. As we all know, asthma is a very prevalent disease. It affects 385 million people in 2015. It causes a big burden for the public health system, especially in the countries with low or middle income countries as Lebanon. The asthma study, which is an epidemiological study that was done in the Middle East and Africa, showed that 31% only of our Lebanese asthmatic patients had adherence to their asthma treatment in Lebanon. And only 20% of our Lebanese asthmatic patients are controlled, despite us having all the effective treatments available in the country. This is why the Asthma Q project was launched with the objective, first of all, to increase the public awareness on asthma, making the patients understand more and more their symptoms and its consequences, and to try to guide them through specialized referral. After increasing this public awareness, we would love to increase the level of asthma control of the Lebanese asthmatic patients. How the project was done, any patient who would go to a pharmacy, we chose like 90 pharmacies in the countries. The patient who would go to the pharmacy to buy his treatment would be, then he will go inside the pharmacy. He will be directed to an ATM like Asthma Q test, where the patient will have to answer questions regarding his level of control. The questions are according to the GINA guidelines regarding the level of control in a manner that the patient will understand. He will have his results on a paper, and the patient will have this paper with him. On this paper, we will have the website of the society, on which we put a video of awareness, where the patient, in a very easy manner for him, he will understand the diagnosis, the signs, the symptoms of asthma, and about the treatment of asthma. Also, he will have a list of the specialists that he can go and see to follow up for his treatment. Then this material, along with this material, the patient or can go to this website, or he can go to see his doctor. And if he comes back to the pharmacy with the stamp on this paper result, he will receive a free peak flow meter that will help him to control his asthma disease progression. The project was launched on the 17th of September 2020 in the Ministry of Public Health with the presence of the minister. And it was followed by a big media appearances for the committees with the appearances on the TVs, the radios, and the social media. Unfortunately, we could only follow the project for 3 months because of many problems, mainly the situation in Lebanon being the economical, the security reasons, and after the lockdowns related to the COVID pandemic. During this period of 3 months, we could see 25,000 patients. were done then. And of these, we had 45% of the patients who were partially or uncontrolled asthmatic patients. Then these are the questions that were asked to the patient. And like I said, we could follow 25,000 patients, asthmatic patients. Of these, we could have 13,000 who were controlled. The remaining were between uncontrolled or partially controlled patients. The difference between the different districts of the country were not very important. They varied between 35% and 55% as the rate of uncontrolled asthma in our country. We hope that we will continue this project. It will not stop here. As long as now we are in lockdowns, partial lockdowns, we cannot continue, but we hope that in very few time we will continue the study. Thank you.
Thank you, Celine. I think I would like to, in the name of all pulmonologists in Lebanon, I would like to thank Dr. Aoun and the group that work on that project, because it really gives us a real idea of what's going on in our country as far as asthma control. So from what I understood is that you are willing to keep going with the project when lockdown will be better, or when the situation will be better, and the goal is to reach what number of patients, or what is the specific goal?
Actually, the first goal was not a number, it was a period of time that could not be reached. We were talking about 1 year first, and then we'll see if we maintain more. Now, definitely the time will change. It's not going to be 1 year because already we did 3 months. Hopefully when we begin again, maybe we'll see, but 25,000 already in 3 months, it's a very good number. We'll see, hopefully when we will again relaunch the object, we can see more patients.
Okay, in your preliminary data, did you see any difference between the regions as far as control, partially control, or totally control?
Like in one of the slides.
In the areas,
yeah, exactly. There are some areas. Exactly. This is very true. There are some areas where the control is better. The differences are not very much related. In Lebanon, it's like not very far away. If somebody lives in a region and he can go to buy from the pharmacy from the other region, then it's not very, definitely the very far places like Akkar, Tripoli are very far from Beirut, but somebody living in Beirut can have his doctor in Matan, for example, and he goes buy from the pharmacy, then this is going to be a lot, I think it will be more homogeneous at the end of the study.
All right. Thank you, Celine. Great work.
Thank you.
Let me see, there are any other questions?
Good afternoon and welcome again to this afternoon session in Hot Topics in Pulmonary Disease. Our next talk, titled Coronavirus in the Lung, What We Learned 8 months later, will be given by Dr. Pierre Iddi. Dr. Iddi is an American board certified in pulmonary critical care and sleep medicine. After graduating from the AUB in 1990, he specialized at Columbia University in New York. He practiced 10 years in Pennsylvania as the chair of pulmonary critical care medicine and the director of the sleep lab at Uniontown Hospital. In 2011, he returned to Lebanon to be the head of the medical ICU in Centre Hospitalier Universitaire Notre-Dame de Secours in Jbeil. He is an associate professor at USAC University, where he teaches at the medical school. Dr. Iddi has several publications and patent inventions. Please help me welcome Dr. Iddi. Thank you.
Thank you, Dr. Zain. And like everybody, I want to start my presentation by being grateful to the Scientific and Organizing Committee and Lebanese Pulmonary Society to give me this opportunity to share with you our experience with COVID-19 patients. We at CHUNDS, Notre-Dame de Secours Hospital, we are an officially designated hospital that covers the region in Lebanon, northern of Beirut, more specifically north of Jounieh till the borderline with Syria. It's a large population, and we had a section of the hospital designated to take care of these patients. Now, no matter what we say about coronavirus or COVID-19, we are still in our infantile stage of knowing exactly how this virus behaves. The symptoms, they spread a spectrum from completely asymptomatic patients to being fatal. In the respiratory system, you know, we divide it as upper airways and lower airways. In the upper airways, it can be loss of smell and taste, upper respiratory infection symptoms, pharyngitis, laryngitis, and in the lower airways, the virus can affect the bronchi and the pulmonary parenchyma. In the airways, it can lead to cough that can be mild, moderate, severe, and in the pulmonary parenchyma, alveolitis. It presents itself as bilateral scattered ground glass infiltrates that you're all familiar with. These can be mild, moderate, or severe. Mild, moderate, they can recover, but if they keep progressing in severity, they can lead to acute respiratory distress syndrome with respiratory failure, and this is what I'm going to focus on. So COVID-19 ARDS, or CARDS, if we start with the basic anatomy, this is an acinus, and there's this alveolus with the capillary surrounding it here. If we present it in a cartoon way, this is a normal alveolus, and this is an acinus with the capillaries surrounding the alveoli. In CARDS, or COVID ARDS, we have viral replication inside the alveoli with no involvement of the respiratory membrane, of the pulmonary interstitium, of the alveolar cells, alveolocytes and pneumocytes. And we can have also replication of the virus with interstitial edema. The first type is called type L, and the second type is called type H. As the disease progresses, type L becomes type H. Now, regardless of which type, both can lead to hypoxemia. ARDS type L, we have loss of alveoli, loss of surface area, and this can lead to hypoxemia. Now, why do we call it L? Because it has low elastance, and elastance is the reverse of compliance. So the lung is highly compliant. And since we're losing alveolar surface area, we have a low VQ ratio, ventilation to perfusion ratio. The lung weight is low since we don't have much edema. And if the patient ends up on a respirator, even with higher PEEP, we have low recruitability. So the alveoli are not collapsed. In type H, on top of losing alveolar surface area, we have an increase in the respiratory membrane thickness due to edema. So the gas exchange has to go through a thicker membrane, a bigger distance. So we call it H because there is high elastance, which means low compliance. The lung is stiff. And since we have alveoli that are inflamed and the respiratory membrane is thick, there will be a high right to left shunt. There is a high lung weight because there is edema of the lung. And if the patients end up on a respirator, going on higher PEEP can lead to better recruitment of alveoli. So there is a high recruitability. Now, regardless of the type, gas transfer always obeys the law of diffusion. And if we go back to the formula of diffusion, diffusion is directly proportional to the pressure gradient, to the alveolar surface area, to the solubility of the gas, and inversely proportional to the distance across which the gas is going to diffuse, and to the root square of the molecular weight of the molecule. The solubility and molecular weight are fixed for the gas. In type L, we lose alveolar surface area. In type H, we lose the alveolar surface area and we have a higher distance of the respiratory membrane. So the diffusion will decrease. In order to maintain a normal diffusion, we have to increase the pressure gradient of the gas. And when we talk about oxygen, we start adding oxygen. We go to 100%, then double source or non-rebreather face masks. Then we go to high flow nasal cannula. And if these don't work, we have to go to mechanical ventilation. Now, mechanical ventilation can start as a non-invasive. And if it doesn't work, we go to invasive ventilation. Invasive ventilation will certainly increase the intrathoracic pressure. It will increase the alveolar pressure. and it would lead to alveolar hyperinflation. And certainly the healthy alveoli, which are more compliant, will distend more than the inflamed or infected alveoli because they are less compliant. And if we take a break and look at it as a presentation, when we start pumping pressure inside the alveoli, the healthy alveoli will distend. And here we can compress the capillaries around the alveoli. And if the alveolar pressure goes higher than the pulmonary systolic pressure, we will be creating a zone 1. Remember the zoning of the lungs, zone 1, 2, and 3. So we will be creating dead space. And in between the distended alveoli, the stiffer alveoli will be compressed, and there will be a shunt or blood passing from right to left. And this will be also a recipe for hypoxemia. So both the dead space or the shunt will lead to worsening hypoxemia and later on hypercapnia. And the distended alveoli will be the cause of the high-risk barotrauma, which we see commonly in patients with COVID-19, whether pneumothorax or pneumomediastinum, 15% with a 64% mortality. So let's go back to this slide. So the infected, once we start we start mechanical ventilation, this can lead to worsening hypoxemia. Then we talk about proning. Why prone positioning has gained success in COVID-19? If we go back to the anatomy, we know that the dorsal alveoli have better vascularization. And when we put the patient in the prone positioning, then we will unload the gravitational weight and the weight of the mediastinum and the mediastinal structure, whether the heart or the vessels, on these dorsal alveoli. Then the pleural pressure posteriorly, dorsally, will be more negative, which would lead to stretching of these alveoli, and there will be better ventilation to the dorsal alveoli when the patient is in the prone position. Now, due to the dependent edema, when the patient is lying supine, ventrally the alveoli are not edematous. So when we put the patient in a prone position, there will be better perfusion to these alveoli ventrally. I hope you're following me. And the dependent alveoli that are filled with edema would start draining ventrally. So these mechanisms lead to better ventral and dorsal ventilation perfusion. And when the dorsal alveoli will be draining ventrally when the patient is in the prone position, will also unload the filling of the dorsal alveoli. So historically, since the 70s, we've been doing studies on prone positioning, and the typical ARDS don't do as well with the prone positioning, while in type L ARDS of COVID-19, they do great. This is why prone positioning gained success for COVID-19. Going back to this slide again, if prone positioning doesn't work, we go for ECMO, and if ECMO doesn't work, the patients will usually die. And early reports, you know, death was reported up to 90, 95%. Now it's lower, and we're waiting to see in this new wave what will happen. So this cycle, from once we start mechanical ventilation, I call it the degrading cycle. Okay, what can we do about this? Let's go back to physiology. If we take the alveolar pressure and the pleural pressure, during resting at the beginning of the breathing cycle, i.e. at the end of expiration, just before inspiration, the pleural pressure is -5, and this is a resultant of the tendency of the chest wall to recoil and tendency of the lung parenchyma to collapse, and the alveolar pressure is 0. During inspiration, when we expand our chest wall, the pleural pressure becomes -7.5 centimeter of water, and it can go as low as -25 or -30. This will translate as a -1 in the alveolar space, which is enough to suck air from the atmosphere down the alveoli. During expiration, when the chest wall goes back to its normal position, the pleural pressure will go back to -5, and this would squeeze the lung parenchyma, and it will translate into a pressure of +1, which is enough to expel the air out of the lungs. Why I'm discussing this physiology? Because if we do alveolar pressure minus pleural pressure, we get the transpulmonary pressure. And this pressure reflects the stretching of the lungs. And whenever we talk about stretching of the lungs, we talk about lung injury. And patients with ARDS, they can be breathing spontaneously early on, or they might end up being intubated later on. So even in spontaneously breathing patients with ARDS, when they do a lot of effort to breathe, this can lead to something we call patient self-inflicted lung injury. It's in a way similar to once we intubate the patients, we all know about the ventilator-induced lung injury. Now, for the patient self-inflicted lung injury, there has been reports about doing early prophylactic intubation, which we don't practice at our center. We try to delay intubation as long as we can. Sometimes we have patients deeply desaturated, but they are comfortable working on their mobile phones, and we just wait. I've seen patients as low as in their 60s, and they're comfortable crossing their legs, talking, and we just wait. And patients with ventilator-associated, ventilator-induced lung injury, we follow the lung protective ventilation, low tidal volume, low respiratory rate, permissive hypercapnia, and deep sedation. Now, stretching of the lungs means, or it reflects lung compliance. And you've all seen this curve on the ventilator that we call hysteresis, and it reflects the work of breathing. So if we go again back to physiology, hysteresis, it's this curve that we all teach to our students, and we look at it from the width standpoint and the slope, the angulation standpoint. In COVID-19, in type L, when we have loss of surfactant, this hysteresis curve would become thicker, fattier, bigger in width. While whenever we have loss of elastin or increase in collagen, it will bend down, the slope of it will go down rather than it becomes thicker. Certainly, if we have combination of both, we can have any combination of both curves. So in type L, the minimal sensation of dyspnea is due to hypoxemia, which is reversed by oxygen administration. While in type H, the dyspnea is due to mechanical stiffness and it requires ventilatory support. I think enough of physiology. Now that we know the pathology of COVID-19 and the pathophysiology of it, how can we intervene to reverse it? So what I call the novel solution, I might be right, I might be wrong, the reasoning. If we are to reverse the degrading cycle, we have to respect the transpulmonary pressure, and we have to lower the work of breathing. Now, how can we do that? We must rely on the patient's feedback to decide on the various needs or modes of ventilation and ways of adaptation and keeping the patients comfortable. And the goal can only be achieved if we can support the patient, not forcefully ventilate them, if we can support them. And this support has to be passive, continuous, and without interruption. For how long? We have to wait and wait and wait till the viral load reaches its maximum level, and then we start seeing recovery. And we all know that it can take a protracted course, 2 to 3 weeks, up to a month, and sometimes more. Now, out of this slide, you can see the two words, feedback and support, that stick out in red. So we're talking about feedback, meaning patients should be awake, and support the patient, meaning the patient should be spontaneously breathing on pressure support. Certainly, if we can ventilate a patient who's awake and breathing spontaneously, we can have better hemodynamic stability and better communication. So we're talking about early tracheostomy. Right off the bat, immediately, day 0 or day 1, we do a tracheostomy and we let the patient breathe spontaneously on pressure support and PEEP. As much as the patient wants, we give him pressure support and PEEP as much as we need to recruit alveoli if we need. Now, if you look at it, you can say, well, it's similar to non-invasive ventilation. Why don't we do that? Well, this goal cannot be achieved with non-invasive ventilation because the delta pressure between the inspiratory and the expiratory is too large. It makes the patient intolerable to the mask. And then we cannot put non-invasive ventilation 24 hours, 7 days a week. Many patients are apprehensive due to hypoxemia and they cannot tolerate the interface. And many patients cough, they cough a lot and they expectorate. And how can they do that with non-invasive ventilation? Nasal congestion and epistaxis becomes a problem if we need to use the non-invasive ventilation for a long period of time. This is why helmet has been felt to be superior to the face mask. And if we cannot feed the patient, we have to go for enteral feeding. What's the downsides? Wow, it's too aggressive to do tracheostomy day one. Well, COVID-19 ARDS is an aggressive disease. And if we are to be ahead in the game, we have to think physiology, we have to think differently, and we have to think out of the box. Why? Because alternatives using the standard care have been less than rewarding. Now, the downsides, would patients and family accept it? Yes, it's difficult to convince them, but ultimately, eventually, they will accept. And personally, this is why I'm sharing my thoughts, my experience will come later on. I've been practicing this since September 22nd, to be exact. Now, what about exposing the staff during the procedure and afterward? Well, during the procedure, we invented or we made a protective shield which is very efficient. I don't know if it shows here. It's a transparent shield with a piece of plexiglass that we use for intubation. And we do percutaneous dilatation tracheostomy. We don't do surgical tracheostomy. It's percutaneous dilatation tracheostomy. We have 3 healthcare providers in the room. Me, or 1 physician, 1 nurse, and 1 nurse aide. And this is how we do the procedure. I don't know if you can see it here. It's a simple procedure done, and this is the piece of plexiglass that secures a clear vision. Now, patients are usually kept sedated till next day, just in case they have some pain, some uncomfort, we keep them sedated till the day after. After the procedure, exposure to the staff, this is similar to the breathing circuit. It's a closed circuit, and there shouldn't be much exposure. Now, once the patients are awake, if they want to talk, we can deflate the cough, and the exposure would be similar to the extubated patients who are in our unit. Now, again, if safety norms are followed and the staff are wearing adequately the personal protective equipments, exposure should not be a problem. So what have we learned? We've learned that these patients have a huge respiratory drive, and this has been reported in the literature. The average is 15 to 20 liters per minute, and I've seen 25, 30 liters per minute. Type L, they take a huge tidal volume, 1.5 liters, but their respiratory rate is the same, about 10 per minute. While type H, they take a normal tidal volume, but they are tachypneic, around 30 breaths per minute. Why? Type L, because they are air hungry, they have this air hungry sensation, they generate a lot of negative pressure. So we have to support them with pressure support to maintain a physiological transpulmonary pressure. And because their lungs are compliant, they generate a huge tidal volume with a normal respiratory rate. While type H, because of stiffer lung, low compliance lung, they reach their maximum stretching or stretchability or expansion with lower pressure support. So they compensate by tachypnea. When we do blood gas, both types, they have low PCO2, alkalosis, high pH, with borderline oxygenation. Now, type L usually requires lower oxygen requirement early on during the disease. Type H, right off the bat, they need higher oxygen requirement. As the disease progresses, as I said before, when type L becomes like type H, oxygen requirements will increase, and standard ventilation strategies of ARDS will be applied, which is the lung protective ventilation, the permissive hypercapnia. So how do we manage? Things to monitor: tidal volume, respiratory rate, and minute ventilation. This is all what we need. Certainly the peak pressure is a key here, and it's always, always, always the pressure support plus the PEEP that we can control. So how do we manage the pressure support and the PEEP? Arterial blood gases, ABGs, are at the core of this strategy. We know that ABGs, when we look at them, we divide them as ventilation and oxygenation. Ventilation will dictate on us how to use the pressure support. We go up or down on it, we increase it or decrease it based on the acidosis or alkalosis, hypercapnia or hypocapnia. And what determines oxygenation is the FiO2 and the PEEP. Type L, as mentioned earlier, there is low recruitability. So we don't need PEEP more than 5 to 8 centimeters of water, while type H, we go up to 12, 15, and sometimes higher to recruit more alveoli. So how do we manage? Unless needed, when patients are very comfortable, type L, they can be watching TV, we can get rid of several routinely used wires and monitors. We can get rid of cardiac monitors, NG tubes. They can eat Foley catheters. They can ask if they want to urinate. And unless needed, we can get rid of several routine nursing care, such as prone positioning. And this is a huge unloading from the nursing staff to turn the patient on their tummy. We don't need passive physical therapy anymore. Patients are awake. And most importantly, we don't need routine mouth hygiene. Now, what we really need is a pulse ox that can give us oxygen saturation and the heart rate, and we need an arterial line to check the blood pressure and get frequent ABGs. Now, patients can sit, feed themselves, watch TV, walk near the ventilator even, and mobile phones. I don't know what to say about mobile phones. They are good or bad. Should we allow them or prohibit them? They are important for the patients to have, but sometimes they make phone calls that result in recipe for some scary ideas for family members and too many phone calls back to us. So this is something we're looking into. It. 2 questions before I finish. For those who agree with me and for those who disagree. Let me start with those who disagree. Those who disagree with the physiological and pathophysiological reasoning. If we believe that COVID-19 ARDS takes a protracted course on the ventilator, then patients who end up on the respirator will either succumb or they will end up with tracheostomy anyway. So why not doing it early? What's the harm in doing it early on? And for those who agree with me, with the physiological and pathophysiological reasoning, then early tracheostomy, I'm not saying it is the solution. It's not a treatment. It's a way of thinking. Then it might be the solution. Then the question becomes, should we think the same way for the standard ARDS patients instead of doing the lung protective strategies? Well, this is an open question, which is certainly worth doing further studies and further research to answer it. In summary, if the teaching is do no harm with mechanical ventilation, and if early tracheostomy with spontaneous breathing provide better hemodynamic and higher chance of survival, why don't we apply it? Thank you.
Thank you so much for this comprehensive review. I have one question from the audience. What's the mortality rate with this technique? Is it better than before 22nd of September? Do you have any data to support this?
What I can tell you, till now, since the 22nd, I have 0 mortality in my unit, but I have very, very sick patients. So I don't expect to have 0 mortality. Now, it's too early to talk about series of survival and mortality, but what I can tell you, we're not seeing anymore what we've seen in the first wave of COVID-19. So this is, my presentation is to share with you what we're doing, and hopefully later on, I can present a series. I'm not doing a study, by the way. This is not a study. I'm not taking placebo control. I'm just doing something that I will end up doing anyway 2 weeks down the line. So why don't I do it early on? And this will give me the freedom of doing better ways of ventilating the way I put it in. So till now, I have no mortalities. But it doesn't mean that I will not have mortalities. But instead of having, for example, 80% mortality, 20% survival, I hope to flip the coin in a 20% mortality, 80% survival. We'll wait and see. We'll wait and see. Certainly, if the results are really worth pursuing this strategy, we need to do it in a multi-center within the nation, or even maybe internationally. Already, I've been in touch with reference physicians globally to present my idea and see if it works. Actually, I don't know if Dr. Marini is with us. He promised to join us, John Marini from Minneapolis. I can't tell if he's with us or not. If you're with us, Dr. Marini, oh, he is. You can, if you have a question, Dr. Marini, please go ahead. How to sedate our patients. Sometimes, even on spontaneous breathing, I might be forced to sedate the patient. I'm using Dormicum, which is Versed in the United States. It's a benzodiazepine with some amnestic effect. I use propofol and fentanyl because of if they are in pain or they're uncomfortable. So I use these three. And despite using these three medications, patients, because of the high respiratory drive, they can still breathe enough. And we monitor with the blood gas to make sure that we're not suppressing the respiratory drive too much. So sometimes, yes, I do sedate my patients despite putting them on spontaneous breathing. Now, when they progress in their disease and I cannot control them, I might add a neuromuscular blocker and go with the protective lung ventilation.
I just want to comment, and you will correct me. So this approach is based on personal experience. That's what number one. There's two caveats with this. The first
well, actually, Dr. Zain, I don't want to interrupt you. There has been two studies about tracheostomies in COVID-19, but they were done between day 10 after 1 week. And
I understand that part. My question is that you're doing early tracheostomy, assuming that everyone is going to end up being on the vent for a long time. This have changed a lot since new therapies, and I'm sure the new therapies are going to make their way to Lebanon. Our mortality rate on mechanical ventilation, people who are ventilated are only 21% of the treatment. So this technique is going to be adjusted as we progress, and probably the best approach to do at this point is maybe to have a randomized controlled trial just to look into those things. That's the only thing I'm just cautioning. I'm not saying what you said is wrong and doesn't have a mortality advantage, but that's something I need to caution everyone.
Yes, I agree with you. And I'm not saying that we found a solution. I'm just sharing my ideas with you, and time would let us know. And if we can find a medical cure, certainly why to go through early tracheostomy? Now, why I'm not reluctant to do early tracheostomy, I'm not here to defend this approach, but this has been the standard of care to do trach, no scarring, no subglottic stenosis, and thank God we haven't had any complication. I've been doing this for 10 years and more. So for me, it's a simple procedure, and it gives me a safety margin or a flexibility margin enough to manage my patients. And as I said, for the third time, I'm repeating it, we will be sharing our data with everybody once we have more number of patients. Right now, I have a little bit more than a handful of cases.
Dr. Daman, two more questions, if you don't mind. I think the second one we answered already. What about the role of other treatment in severe COVID-19? And I'm sure the answer will be when
this is a question for me. Well, we are in the Solidarity study where we randomize patients between Actemra, Remdesivir, or interferon gamma. And I'm probably wrong, but in my book, if we are randomizing between 3 drugs, then there is no gold standard treatment yet. If we have Remdesivir, we use it certainly, but I hope it's widely available. And short of it, we have to do what we have to do.
I understand. Thank you so much for this comprehensive review. We have to move to our next session.
Okay.
Now we're going to move to our next session by Dr. Ayman Khair, titled Thoracic Ultrasound, the New Stethoscope. Dr. Khair is a pulmonologist, est un pneumologue au département de pneumologie CHRU de Barbois-les-Nancy. Il est un praticien hospitalier à temps plein responsable de l'unité des soins intensifs respiratoires au Centre hospitalier régional universitaire de Nancy. Il est aussi un membre de la Société de pneumologie de la langue française depuis 1990 et de la Société de réanimation de la langue française depuis 1993. Dr. Kher est un membre du collège lorrain de pathologie thoracique depuis 1992. Please help me welcome Dr. Kher.
Madame, Monsieur, chers collègues, je remercie le comité d'organisation de m'avoir donné en fait l'occasion pour parler d'une technique certes ancienne, mais dont les indications se sont élargies en pneumologie. Et je vais essayer de vous convaincre en fait que l'échographie représente un outil précieux du pneumologue, au même titre que le stéthoscope. Je n'ai pas de conflit d'intérêt dans le cadre de cette présentation. Et je vous propose un rappel sur les bases de l'échographie pour passer ensuite aux indications les plus connues au niveau de la plèvre, pour aborder ensuite les indications au niveau du poumon et le diaphragme. Le principe de l'échographie est l'émission d'ultrasons avec une fréquence supérieure à 20 000 Hz, donc inaudible pour l'oreille humaine. En échographie médicale, on utilise même des fréquences largement supérieures. Ces ultrasons vont se propager de proche en proche dans un milieu diffusant, en l'occurrence ici l'eau, et vont se réfléchir lorsqu'ils rencontrent un obstacle comme les roches. C'est le principe en fait du sonar qui a été utilisé en 1917 par les Alliés. L'utilisation médicale date des années 40. En radiographie en fait standard, c'est la densité des organes qui nous intéresse. En échographie, ce qui nous intéresse, ce sont en fait les interfaces. C'est ce qui va créer en fait l'image échographique. Sur ce schéma, donc vous avez une sonde qui va émettre des ultrasons qui vont traverser des tissus. Ici, la sonde est posée sur la paroi thoracique et à chaque interface, donc entre deux tissus, il va y avoir des phénomènes de réflexion avec des allers-retours et c'est ce qui va nous renseigner en fait sur la distance ou sur la profondeur de la structure et sur sa nature. Il est important en fait de connaître les écostructures élémentaires. L'os, on sait que l'os représente en fait un obstacle aux ultrasons. Donc, on va avoir une image hyperéchogène, donc avec derrière un cône d'ombre pure, puisque donc on va avoir des phénomènes de réflexion intense et l'os ne permet pas de passer en fait les ultrasons. Ici, vous avez l'exemple, vous avez une côte et derrière un cône d'ombre pure. Ici, pareil, une cône et un cône d'ombre pure. Ceci est valable en fait sur tout l'organisme. Vous avez la vésicule biliaire, vous avez un calcul, donc une image hyperéchogène et avec un cône d'ombre pure derrière. L'eau, par contre, est diffusible, donc elle permet de diffuser, de transmettre les ultrasons. Du coup, on va avoir en fait une image anéchogène et derrière en fait un renforcement postérieur du fait de la présence d'interfaces. Ici, donc, vous pouvez voir un épanchement pleural, donc anéchogène, avec un renforcement postérieur. L'air, par contre, ici, donc, on va avoir, l'air représente également un obstacle aux ultrasons. On va avoir donc une image hyperéchogène, mais derrière, on va avoir ce qu'on appelle un cône d'ombre impur du fait d'une dispersion en fait des ultrasons. Je vais aborder maintenant en fait les indications et donc afin de respecter le temps, je vais tout simplement survoler les indications en présentant à chaque fois soit un cas, soit en fait une étude. L'échographie donc thoracique permet de diagnostiquer l'épanchement pleural, de le caractériser, de guider les gestes sur la plèvre et de diagnostiquer un pneumothorax et de suivre l'évolution après drainage. En 1910, en fait, la Société britannique de pneumologie avait publié une monographie sur la prise en charge, ou une monographie sur les recommandations pour la prise en charge des pathologies pleurales, avec donc un chapitre dédié aux procédures pleurales et à l'échographie. Et la conclusion était que tous les gestes pleuraux doivent être réalisés sous guidage échographique. Alors, ceci est bien évidemment basé sur plusieurs études. Vous avez cette étude qui est ancienne, mais qui est très intéressante, qui avait en fait comparé la sensibilité et la spécificité de l'échographie par rapport à l'examen clinique et à la radiographie thoracique. Et comme vous pouvez le voir, en fait, la sensibilité de l'échographie est largement supérieure à l'examen clinique et à la radiographie thoracique, avec une excellente spécificité et une meilleure exactitude. Il s'agissait de patients en fait de réanimation hospitalisés pour un tableau de SDRA. L'échographie permet également d'évaluer l'abondance de l'épanchement pleural. Vous avez ici donc un épanchement pleural, mais avec une courbure de la coupole nervaire qui est conservée. Ici, vous avez un épanchement beaucoup plus abondant avec une courbure inversée. L'échographie permet également de diagnostiquer ou de visualiser un cloisonnement. Ici, vous avez donc une pleurésie infectieuse compliquée et seule l'échographie permet de visualiser ces cloisonnements, y compris par rapport au scanner thoracique. L'échographie permet également d'orienter parfois le diagnostic, puisque un transsudat est toujours un échogène, une pleurésie échogène ou cloisonnée est toujours un exsudat. Par contre, un exsudat peut être en fait un échogène. L'échographie permet également de détecter des signes de malignité, le signe du plancton, la présence en fait de nodules au niveau de la plèvre pariétale ou du diaphragme, la constatation d'un épaississement pleural ou de lésions nodulaires avec donc une bonne sensibilité et une bonne spécificité. Ici, vous avez donc le signe du plancton. Vous avez en fait un liquide échogène tourbillon. C'est toujours un exsudat. Bon, ce signe est présent dans environ 80% des pleurésies néoplasiques. Bien évidemment, il n'est pas spécifique. La constatation de nodules ici diaphragmatiques est également fortement évocatrice d'un envahissement pariétal. L'échographie permet également d'améliorer l'efficacité des gestes pleuraux. Dans cette étude en fait prospective, les auteurs ont comparé l'examen clinique à l'échographie thoracique pour le guidage des ponctions en fait pleurales. 67 patients consécutifs chez qui on suspecte la présence d'une pleurésie basée sur la clinique, la radiographie thoracique et le scanner, et on demande en fait aux collègues présents de nous donner en fait de fixer un site de ponction qu'ils jugent optimal. Et donc, du coup, 255 localisations ont été fixées. Et on considère que l'épanchement ou la ponction n'est pas appropriée si la pleurésie est inférieure à 10 mm. Dans 2/3 des cas, les collègues disent c'est bien, je suis formel, je peux j'ai fixé donc un point de ponction, et ils ont raison effectivement dans 85% des cas. Mais dans 15% des cas, le point de ponction qu'ils ont déterminé correspond à la rate, au foie, au poumon, etc. Dans 1/3 des cas, les collègues, toujours donc basés sur la clinique, la radio, le scanner, disent que je ne peux pas déterminer un point de ponction, et l'échographie, dans plus de 50% des cas, permet de trouver un point de ponction. L'échographie augmente également la sécurité des gestes. Dans cette étude rétrospective, 342 ponctions, lorsque les collègues se sont passés repérés uniquement sur la clinique, il y avait 18% de pneumothorax. Lorsque la ponction était basée sur un repérage échographique en radiologie et la ponction avait été faite dans un deuxième temps au lit du patient, on a également 15% de complications, dans ce qui est peu différent finalement du repérage clinique. Par contre, si le repérage avait été fait, repérage échographique au lit du patient, vous voyez que les complications sont nettement moindres. Ceci est facilement expliqué par ce schéma. Donc, c'est l'importance en fait de la position dans l'évaluation de l'abondance de l'épanchement. Ici, la patiente va en radio. Le radiologue, elle est dans cette position. Le radiologue repère effectivement cette distance et elle est de 35,9 mm dans cette position. Lorsque la patiente remonte dans sa chambre, elle est installée avec un oreiller, etc. Et vous voyez en fait cette distance sous-pulmonaire, elle n'est que de 13,9 mm. Donc, il est inutile en fait de faire le signe de croix. Et si on veut se baser sur l'échographie, il faut faire la ponction en même temps. L'échographie permet de guider les procédures pleurales, de déterminer le meilleur point de ponction, et on peut même suivre l'aiguille lors de l'évacuation. Il faut bien évidemment toujours repérer la coupole diaphragmatique. L'échographie permet également d'augmenter la rentabilité diagnostique ou la rentabilité des gestes pleuraux, c'est-à-dire en fait tout ce qui est éco-visible et éco-ponctionnable. Dans cette étude, je ne sais pas si vous avez toujours recours à des biopsies pleurales à l'aiguille. Cet auteur en fait a comparé la sensibilité diagnostique sous écho, des biopsies pleurales à l'aiguille, sous écho et basé sur la clinique, le scanner, etc. Bon, dans les deux cas, si vous voulez, on récupère du tissu, donc c'est un geste technique. La tuberculose, c'est une atteinte diffuse, il n'y a pas de différence. Par contre, en fait, on a une meilleure, si vous voulez, rentabilité pour les cancers, puisqu'on peut localiser, si vous voulez, l'endroit suspect où on peut ponctionner. Donc, la Société américaine de médecine hospitalière, en 2018, recommande bien évidemment la réalisation d'échographie pour tout geste pleural pour augmenter le rendement et diminuer les complications. Alors, l'échographie permet un diagnostic rapide des complications. Ici, ce sont des patients de réanimation, hospitalisés en réanimation, qui ont chez qui on avait, ils ont eu en fait des ponctions pleuraux et ils ont repris en fait l'ensemble des articles. Donc c'est une méta-analyse. On voit la supériorité en fait de l'échographie par rapport à la radiographie thoracique pour diagnostiquer la survenue d'un pneumothorax par rapport avec une excellente spécificité. Donc l'échographie est supérieure à la radiographie thoracique pour la détection du pneumothorax et doit la remplacer. D'ailleurs, la Société de médecine hospitalière maintenant dit qu'il ne faut pas nécessairement faire une radiographie thoracique après une ponction si le signe du glissement est conservé. Alors, comment on diagnostique un pneumothorax en échographie? Par la disparition du poumon normal. Ici, vous avez un aspect normal avec cette ligne pleuropulmonaire donc le compte d'ombre impur, ce glissement pleural, et en mode TM, on a ce qu'on appelle le rivage, et puis des lignes B. Donc, en cas de pneumothorax, on a donc ce qu'on appelle le signe du code barre qui remplace le signe du rivage. Et enfin, quand on a un pneumothorax en fait partiel, on a une alternance entre un code barre et signe du rivage. Alors, j'ai repris en fait ici cet auteur dit ne pas faire donc d'échographie avant une intervention sur la plèvre est indéfendable. Au niveau du poumon, on peut diagnostiquer, on va voir donc un syndrome alvéolaire, un syndrome interstitiel et un avantage certain également dans les masses ou les nodules périphériques. Ici, vous avez un aspect typique d'un syndrome alvéolaire, donc échographique. Bon, je n'ai pas trop le temps, je pense, de détailler, mais vous avez donc une image assez caractéristique d'un syndrome alvéolaire. Et cet auteur donc, a comparé la sensibilité et la spécificité de l'examen clinique, donc l'auscultation, de la radiographie thoracique par rapport toujours à l'échographie chez des patients donc, hospitalisés en réanimation pour un SDRA. Et comme vous pouvez le voir, en fait, l'échographie thoracique est beaucoup plus sensible que l'examen clinique ou la radiographie thoracique, avec une excellente également spécificité et surtout une exactitude au niveau donc, du diagnostic. Ici, vous avez donc l'aspect également échographique du syndrome interstitiel avec un aspect, une irrégularité en fait, de la ligne pleuropulmonaire, un aspect un peu feuilleté avec des lignes B. Alors, dans cette étude, en fait, on voit que l'échographie permet une détection précoce du syndrome interstitiel. Ici, 58 cas de sclérodermie, dont 32 au stade précoce. Le scanner a permis un diagnostic de PID dans 88% des cas. Et il y avait une concordance en fait entre l'échographie et le scanner. Par contre, il y avait des faux positifs, c'est-à-dire en fait l'échographie donc montrait plus, on va dire, de syndrome interstitiel que le scanner. L'intérêt, en fait, surtout de l'échographie, c'est sa valeur prédictive négative, qui est de 100%. C'est-à-dire, en fait, si l'échographie n'a pas montré, en fait, de syndrome interstitiel, aucun autre examen ne pourra donc montrer de syndrome interstitiel. Au niveau, en fait, des masses et des nodules, l'échographie est supérieure au scanner thoracique pour évaluer l'envahissement pleural. Et c'est ce qui intéresse, je pense, particulièrement les chirurgiens. Et comme vous pouvez le voir ici, le glissement est respecté. On a donc ce liseré graisseux qui confirme qu'il n'y a pas en fait d'envahissement pariétal, pardon, pas pleural, pariétal. Et l'échographie permet également de réaliser des ponctions sous écho avec une sensibilité équivalente au scanner et un temps bien évidemment plus court avec moins de complications. Moi, je travaille dans une grande structure, donc c'est parfois pour avoir en fait une ponction sous scanner, il faut plusieurs jours, alors que depuis que je fais en fait des ponctions sous échographie, les collègues me demandent si je suis disponible. C'est quelque chose qu'on peut faire au lit du patient le jour même. Bien évidemment, on a accès uniquement aux masses donc, qui ont un contact avec la plèvre, donc les masses périphériques. La dernière indication, c'est l'exploration du diaphragme en fait. Bon, les indications sont multiples. Devant toute surélévation d'une coupole, La recherche, bien évidemment, d'une paralysie diaphragmatique, en particulier en post-opératoire, en chirurgie cardiaque, ou en cas d'envahissement médiastinal, l'exploration d'une dyspnée inexpliquée, en réanimation également, l'évaluation pour évaluer en fait le risque d'échec d'un sevrage, du sevrage en fait, et en traumatologie en fait pour diagnostiquer une rupture diaphragmatique. Bien évidemment, le diaphragme n'est pas visible au travers le poumon, donc on a donc accès en sous-costal à travers soit le foie ou la rate, et le diaphragme apparaît comme une ligne hyperéchogène mobile à la respiration. Ici, vous avez donc en mode TM, vous pouvez voir en fait donc une course diaphragmatique normale qu'on peut mesurer bien évidemment, et il faut toujours comparer les deux côtés, et une amplitude en fait maximale, donc une course diaphragmatique supérieure à 2,5 cm, et une différence par contre entre les deux coupoles inférieure à 50% exclut une dysfonction sévère. En cas de paralysie phrénique, on va avoir en fait un mouvement paradoxal lors du sniff test. Ici, vous avez donc un mouvement diaphragmatique normal en sous-costal. Ici également, et ici vous avez donc un mouvement, vous avez une paralysie donc diaphragmatique, et ici en sniff test, vous avez un mouvement paradoxal. On peut également mesurer la contractibilité du diaphragme en fait, en essayant de repérer l'insertion costale en fait du diaphragme en utilisant une sonde haute fréquence, et le diaphragme apparaît comme une bande hypoéchogène en fait de 2 à 3 mm d'épaisseur qui va augmenter de 20 à 90% en inspiration. Donc, l'échographie thoracique est un outil indispensable en fait pour la prise en charge des pathologies pleurales. Les applications augmentent avec l'utilisation quotidienne, en particulier l'exploration des cancers, le diagnostic et le suivi des pneumothorax, l'exploration du diaphragme. Je souhaite terminer par 2 ou 3 diapositives pour vous parler en fait du G-ECHO, qui est le groupe de travail de la SPLF, dont l'objectif est la promotion de l'échographie thoracique et la formation à l'échographie thoracique. Il a été créé en 2014. Il y a plus de 200 membres actuellement, plus d'une vingtaine de pays, plus de 1000 de collègues donc formés dans 23 centres. Pour rejoindre le groupe, il suffit de s'inscrire en fait sur une liste de diffusion sur le site de la Société de pneumologie de langue française. Et on fait donc dans ces centres des journées de formation donc à la fois pratique et théorique. Et donc à la fin de cette journée, je pense que la personne est capable d'identifier à peu près tout ce que je viens d'exposer. Et donc, il a droit à un certificat, on va dire, de niveau 1, pardon, et qui est donc validé par la SPLF. Bien évidemment, il faut qu'il fasse des échographies donc, et des gestes. Voilà. Donc, je vous encourage également à visiter le site du G-ECHO, et vous pouvez donc même avoir un accès libre sur donc il y a un espace dédié. Et une dernière diapo pour vous dire en fait que la réforme de l'internat en 2017 a introduit l'échographie dès la phase socle, avec une phase d'approfondissement, et que l'échographie thoracique fait dorénavant partie intégrante de la formation du pneumologue donc en France. Je vous remercie.
Thanks, Dr. Khair, for this comprehensive review. It's amazing for all of us who trained before the era of echocardiography, how far we came with these techniques. I don't have any questions, and I think we're ready for the next session.
Good afternoon. It's my pleasure to introduce the next session and the next speaker. The next speaker is Dr. Beatrice Chamy. Dr. Chamy is a really very well educated person. She medically wise. She graduated from Université Libre de Bruxelles in 1989. She has a diploma in tobacology, an MBA in health management, a diploma in medical law, and a diploma in mediation. She will be discussing in the next session vaping-induced lung disease. Dr. Chamy is the Chief of Pulmonary Critical Care Division at Notre Dame Hospital in Jbeil. Dr. Chamy, the screen is yours.
Thank you, George. First of all, I would like to thank the organizer to have maintained this Congress despite the very bad situation we are facing now in Lebanon since 1 year. So I will just start with a small introduction on e-cigarettes. First of all, we should know that e-cigarettes have been introduced in the US market in 2007. And since that time, we have seen an exponential rise in use, particularly amongst teenagers and young adults. So in 2018, we had already 40 million of adults who were currently using e-cigarettes. And it seems that by next year, it will raise to 55 million adults. In Lebanon, I didn't find a lot of study, only one published by the AUB team that showed that 63% of the people who were using e-cigarettes had a very bad level of knowledge regarding the risk of vaping. The other thing that was interesting also is that the people who were interviewed, 12% were already using e-cigarette also. So it's a multi-billion market with more than 500 brands already in the market. And in 2023, most probably the e-cigarettes market will surpass the one of the combustible cigarette. So what is vaping? Vaping is different than heated tobacco because it don't contain tobacco, but it contains an e-liquid. And vaping is defined as the act of inhaling vapor from e-liquid through an e-cigarette. And you can see a small button on this device, which allows the user to increase the voltage and increase the temperature that can increase to more than 300 degrees Celsius. So we have a lot of devices. Now we have the 4th generation, and the problem with this generation is that it contains nicotine salt and not the free-base nicotine, which increase the addiction, particularly among the teenagers. The e-liquid, we have a lot of formulation, more than 60,000 formulation. Most of them contain nicotine with different concentration, with 95% of solvent, which are propylene glycol and glycerin. We have more than 15,000 flavors, chemicals, carcinogen. More than 20 already have been identified. But also some people use the e-cigarette to smoke cannabis like THC or CBD, which contain different kind of solvent and chemical. So the chemical composition of the aerosol depends on the composition of the e-liquid, the device, and the voltage that it's used. And many of those flavoring and additives have never been tested on the lungs, and the effects are largely unknown. So we already know that we have toxicity in the lung, particularly because of the propylene glycol, the THC, some flavorant, heavy metal, and vitamin E acetated. So what about the vaping-induced lung disease? So regarding the long-term, the possible long-term adverse effects are still unknown because to date, no long-term vaping toxicology studies have been done in humans, but we already know that it increased the productive cough and the number of exacerbation in patients who have chronic bronchitis. It increased the prevalence of asthma exacerbation. It increased the predisposition to severe respiratory infection and and most probably increase the risk of cancer. The short-term effect of e-cigarettes have been well described in the literature. We've known more than 200 cases who have been reported, and the name of this disease now is named EVALI for electronic cigarette and vaping product use associated lung injury. And the various presentation of EVALI suggests that we have a non-specific acute lung injury, possibly reflecting a spectrum of disease process rather than a single process. 2012 initial case reports were published, and in last summer, the CDC declared an outbreak in the States. February 2020, already 2,800 patients have been admitted to the hospital. Amongst them, 2.54% died. In Europe, it's still more rare. So what about the diagnosis? How to do the diagnosis of EVALI? So we should have four criteria. The first one is that the patient should have been vaping within 90 days of the symptoms onset. He should present with pulmonary infiltrates. We should have an absence of evidence for alternative diagnosis and a lack of pulmonary infection. So as you can see, the diagnosis of EVALI, it's mainly a diagnosis of exclusion. Clinical features are non-specific at all, but the majority of the patient will present with dyspnea and cough, some with hypoxemia, chest pain, hemoptysis, and which is interesting to know is that some patients can have GI symptoms or constitutional symptoms like fever and chills. The median duration of symptoms before hospital presentation was 6 days, but with a huge range going from the first day to more than 150 days of symptoms duration. We have different type of lung injury or predominant disease, like you can see here in this slide. More than 70% we present with organizing pneumonia, but we can also find diffuse alveolar damage, diffuse alveolar hemorrhage, acute fibrinous pneumonitis with organizing pneumonia, respiratory bronchiolitis associated ILD, acute eosinophilic pneumonia, hypersensitive pneumonitis, and pneumoconiosis. Some cases have been published and described like lipoid pneumonia, but it seemed that it was not properly labeled. So laboratory findings, nothing specific, just an increase of the marker of inflammation, a mildly elevated serum aminotransferase in almost 50% of the patient. And what can be interesting is to do a drug screen, a urine drug screen that can be positive for the tetrahydrocannabinol present in some e-liquid. Regarding the radiologic findings, 100% of the patient will present with bilateral ground glass opacification, which in the majority of the case, we spare the subpleural space and will be patchy. So like we can see in this picture, we have predominant hazy opacity with peripheral sparing. Pathology, in 95% of the case, the pathology that we will find is an organizing pneumonia, diffuse alveolar damage, or acute fibrinous pneumonitis. So here, for example, we have on the CT multifocal ground glass opacity with a sign of organizing pneumonia on the pathology. In this case, we have diffuse ground glass opacity with intraalveolar giant cell organization in eosinophil, which is compatible with an acute lung injury. These patterns is diffuse ground glass opacity and patchy consolidation with diffuse alveolar hemorrhage. So we have different patterns, but we have some characteristics that are common to all those patients. So the majority were men, they were young, and more than 80% of them were using cannabinoid, and most particularly coming from illegal market of self-mixed liquid. And often those patients were also using multiple products simultaneously and vaping from days to several years, but it's still 20% of those people were not on cannabis. The patients who died were a bit older, almost 50 years, and more than 30% of them have alternative or concomitant disease. The pathogen is still unknown, but which is clear is that it represents a toxic inhalation injury like we have with, for example, Cordarone or infliximab. And one of the culprit was incriminated was the vitamin E acetate that were found in the BAL in 95% of those patients. Some cases have been described of acute eosinophilic pneumonia, 4 cases in the literature, cases of bronchiolite obliterans in a young patient who even need mechanical ventilation and ECMO. And also I found 1 case of pneumoconius, which was due to the presence of cobalt inside of the vapors. 1 case of pneumothorax also have been described in a young patient. So I have 1 case, a young patient, 21-year-old man who came to see me some months ago with chest pain and hemoptysis. He was on vaping since 2 years, and on the CT scan, I found some ground glass patchy nodule, and on the bronchoalveolar lavage was almost normal with foamy macrophage. So I think that it might be a case of EVALI. What about the management? Lab tests, screening for urine for cannabinoid, the chest X-ray, CT scan, bronchoscopy to rule out infection. Actually, bronchoscopy or surgical lung biopsy is not more recommended. Regarding the management, the treatment is more supportive care like oxygen, ventilation, and 7 patients were on ECMO, corticosteroid only if worsening with a small dose and tapering over 5 to 10 days. The most important thing is maybe the most difficult for our patient is to convince them to further avoid all vaping products. Which is important for us as physicians is to try to ask our patient about e-cigarettes. So what type of vaping do they use? What kind of product, etc. Which I think we are not doing at the moment. Regarding secondhand smoking, on long term, we don't know if there is some effect, but on short term, we already know that we can find a small airway irritation and airways mild inflammatory reaction. And for the user of nicotine, nicotine can be found in the urine of children who were in presence of their parent vaping. So my take home message, the first one is for us as clinicians, we should consider the possibility of pulmonary illness associated with vaping when patients report recent use, especially when other causes are not identified. Patients using e-cigarettes should be provided with a clear information on the attributable risk of e-cigarettes on health, like addiction and lung injuries. And last but not least, e-cigarettes are not a smoking cessation tool, and we should recommend that our patients to abstain from all inhaling form of tobacco, algae, water pipe, and vaporizes solution. Thank you for your attention.
Thank you, Beatrice. Let me ask, EVALI, is it mainly cannabis related or cannabinoid or adding stuff to the vaping system, or you can see it was just people having regular vaping? So the lung injury that we
EVALI was described in 80% of the patients were on cannabinoid, but still 20% of the people who present with EVALI were not on cannabinoid. So the vitamin A acetate, which was incriminated with the patient who were on cannabinoid, because it's one of the solvents that they use in cannabinoid, but 20% of the people were not inhaling any kind of cannabinoid. So we are sure that we have other culprits.
All right. Thank you very much, Beatrice. Very nice talk.
Thank you. You're welcome.
Thank you.
Hello again. Our last talk titled Difficult to Treat Asthma Before Moving to Biologic is sponsored by Mondi Pharma and will be given by Dr. Pierre Boukhali. Dr. Boukhali is the Division of Pulmonary Critical Care, Medicine and Sleep Medicine and Residency Program Director at the Department of Internal Medicine, American University of Beirut. Medical Center, Beirut. Dr. Abu Khalil received his MD and Bachelor of Science degree at the American University of Beirut before completing his postgraduate training in internal medicine at Ohio State University and his pulmonary critical care medicine at the Cleveland Clinic in Ohio. Dr. Abu Khalil's research interest is in ventilator weaning, COPD, and treatment of sepsis. He has published widely in pulmonary medicine. He is also a founding member of and a past member of the Lebanese Critical Care Society and a past president of the scientific committee of the Lebanese Order of Physicians. Please help me welcome Dr. Abu Khalil.
Good afternoon. I would like to thank the organizing committee and Mundipharma for inviting me to be the last speaker of this successful Congress. Without taking a lot of time, since we're only limited to 15 minutes, I'm going to start. My talk is about difficult to treat asthma. And obviously, today and yesterday, we heard a lot about the biologics and the new treatment for asthma. And I placed this talk just before moving to biologics. So what shall we do? So the term difficult to treat asthma has been found in the literature for a long time. And sometimes you find it under refractory asthma, life-threatening asthma, brittle asthma, so on and so forth. And although most people have a good response to the use of the inhaled glucocorticoid and the long-acting beta-2 agonist combination, asthma remains poorly controlled, and we have seen that over the years in different studies and different epidemiological studies. And sometimes as many as 20 to 40% of asthmatic patients are not very well controlled on the combination, which most of us consider to be the pillar in the treatment of asthma. So much so that back 10 years ago in the ERS, I took this picture of this slide by Dr. Eric Bateman, who said that asthma is out of control and asthma is actually not controlled. So what is difficult to treat asthma? What is severe asthma? Well, back in 2014, there was an ATS-ERS consensus to finally combine all the definition and so that we are all talking about the same thing. So difficult to treat asthma is an asthma that remained uncontrolled despite GINA step 4 or 5 treatment. And that means medium or high dose inhaled corticosteroid with other controller. Or asthma that actually requires that treatment to remain well controlled and reduce the risk of exacerbation. This is difficult to treat asthma. So what is severe asthma? Severe asthma is those difficult to treat asthma in which we have worked on optimizing adherence, inhaler techniques, and in which we have treated coexisting conditions. This is a quick reminder about the GINA guidelines. This came out is not showing very well, but this was taken from the GINA initiative about the level of asthma control between controlled, partially controlled, or uncontrolled. And this is also a quick reminder about the asthma control questionnaire. So what are the main reasons that we have uncontrolled asthma? Well, there are many. First and foremost, we can have poor compliance. And this is very common in asthmatic patients. We can have poor inhaler techniques. We can have incorrect diagnosis. And recently we've had someone who had carcinoid that was mimicking asthma. And we can have people who smoke, who are rhinitis. So actually not every difficult to treat asthma or a difficult to control asthma has severe asthma. They may have vocal cord dysfunction. They may have another disease such as Churg-Strauss. So a lot of difficult to treat asthma do not have asthma or have an alternative diagnosis. So before we start calling someone as having severe asthma, we need to confirm the diagnosis of asthma, نرجع نعيد حساباتنا to look at everything we have looked on before, to check that our patient have adhered to conventional treatment, and to make sure that the coexisting conditions that can exacerbate asthma are adequately treated. And implementation of those simple steps, or I like to call them critical steps, will result in reclassification of the disease in up to 50% of the patients from severe asthma to moderate or moderately severe asthma. So assessing adherence and inhaler technique is therefore critical, since problem with those adherence, that is, and inhaler technique will account for a majority of our cases with uncontrolled asthma. So finally, we went from uncontrolled asthma to severe asthma, and we excluded the other causes. So what do we do before we move to biologics? We can go to bronchial thermoplasty if it's available. We can add tiotropium, and we can consider switching inhalers and going to fine or ultra-fine particles. Methotrexate and macrolide are no longer indicated for the treatment of those cases, and we can, don't forget, antifungal for ABPA. A word about thermoplasty. Bronchial thermoplasty is a bronchoscopic procedure, and it's used to reduce the small muscle mass that the asthmatic have. And the way we do it, the patient will undergo 3 separate treatment visits. In each treatment, they will undergo a bronchoscopy, and during this bronchoscopy, radiofrequency current is applied to the wall of the central airway, and the patient does that on 3 different visits. Obviously, we run the risk. These are patients that are poorly controlled. These are patients that have severe asthma. So doing a bronchoscopy on those patients is not easy and needs to be done in a specialized center. But the studies that came out about bronchial thermoplasty had been promising, although its use is still limited to main center, and the benefit may last as long as 5 years. Tiotropium is another medication that we can use for those patients, even if they are non-smoker. And this is the landmark article in the New England Journal of Medicine, whereby they used tiotropium in asthma poorly controlled with standard therapy. And tiotropium was more effective regardless of what the baseline medication that the patient was taking. And the final conclusion of the article was that in patients with poorly controlled asthma, despite the use of inhaled corticosteroid and LABA, the addition of tiotropium significantly increased the time to the first exacerbation and provided modest sustained bronchodilation. So one last thing we can do before moving to biologic is trying to switching inhalers and maybe moving to an inhaler that provides fine or extra fine particle. And this is in a way the main focus of this talk. So where is this coming from? This is coming from the fact that small airway disease has a major role in asthma. And in this recent review back in, if I'm not mistaken, 2018 or 2017, it says the treatment of asthma, particularly for those with more severe disease, should take into account the extent of small airways and utilizing devices which optimize drug delivery to the small airways. And that is not you know, like an orphan article. This is something that we see again and again in various publications, such as those listed here, spanning from between 2017 to 2020. Fluticasone formoterol in the formulation that is available in the Flutiform achieves higher fine particle fraction for both ICS and LABA, irrespective of the inspiratory flow, and that will lead to a better deposition of the inhaled corticosteroid and the long-acting beta-2 agonist in the peripheral airways of patients with asthma. And this is a study that tells us what happens using the novel imaging technique. But if we change the inhaler, does it really make a difference? I mean, are we doing this as an exercise and then nothing happens, or we're doing it just to go through the motion? Well, I'm going to go through a bunch of studies right now that tells us that changing the inhaler will have a positive impact in the treatment of our asthmatic patient. This is an article published in October 2018, and the conclusion of the article that patients who changed to pMDI had significantly less severe exacerbation, acute respiratory event, and lower short-acting beta-2 agonist inhaler average daily dosage. However, they did have an average ICS daily dose higher than that compared to the matched patient that remained on the DPI, and the costs were in fact similar. In this real-life study, effectiveness of asthma treatment with a fixed dose fluticasone for formoterol. This was a non-interventional study, and essentially it says up to 40% of patients from an N of 555 were initially treated with ICS/LABA prior to study enrollment, and then they were switched to the fixed dose fluticasone formoterol. And in the highlight of the study, essentially there was clinically important improvement in asthma control and quality of life with fluticasone formoterol. There were decreased incidence of severe asthma exacerbation with this new formulation, and these improvements were evident early on, and even if we waited for 12 months. In another study published in Respiratory Medicine 2017, essentially the proportion of patients with well-controlled asthma more than doubled 12 months after switching the patient to a fixed combination fluticasone formoterol HDI. And in this study, it says that the patient also not only their proportion of well-controlled asthma more than doubled after 12 months, but they also experienced a low rate of severe exacerbation and a better quality of life. In another study, also a real-life study, most patients had a moderate at baseline, moderate to severe asthma, and were for the most part uncontrolled. Because of the lack of time, I'm not going to be able to go through all the specific of each study, so I'm just reading the highlights and the conclusions. And in this study, if you look here, you could see that the patients experiencing at least one severe asthma exacerbation decreased from 35.8 in the 12 months prior to the study. So there was a significant improvement and reduction in the number of severe asthma exacerbation when switching to the fluticasone formoterol combination. And that is also true not only for the Western literature, but also for the Eastern literature, as this study from Korea shows, where a higher proportion of patients achieved asthma control. So in essence, one of the most challenging aspects of the clinical management of asthma is determining how to treat patients whose condition is poorly controlled despite the use of inhaled glucocorticoid and long-acting beta-2 agonist. As you all know, in Lebanon, we are facing a lot of financial problem, a lot of medication are going out of stocks. So going back to the basics, ensuring that our patient really has asthma, making sure they know how to use the inhalers, making sure they have the good technique, they are compliant, that we are looking at the correct technique will improve the treatment of our asthmatic patients who are labeled as non-controlled by up to 40%. So my conclusion, and the main conclusion, is that in many patients, up to 50% of your patients that are labeled uncontrolled or difficult to control asthma, we can control asthma very well after optimizing what is considered the standard asthma treatment, which is looking at the inhaler technique, switching to an inhaler, maybe one that has just the fine or ultra-fine particle, adherence to treatment, and systematically being key, addressing the coexisting condition. And it's only then After we do that, and if our patient remain uncontrolled, then we can move to biologics. And with that, I will finish my presentation. Thank you.
And for now, and we're going to move to our closing session with Dr. Zeina Aoun.
Bonsoir. Nous sommes arrivés à la fin de ce congrès, de ces deux très riches journées. Je vous remercie tous pour être là. Je remercie tous les orateurs, tous les modérateurs, tous les gens qui ont été vivement impliqués pour faire réussir ces deux journées, malgré tous les obstacles que nous sommes en train auxquels on est en train de faire face au Liban. Je suis fière qu'il y a eu 640 inscriptions à ce congrès. Il y a eu, sans les speakers, sans les orateurs et sans les modérateurs, il y a eu hier 360 participations et à chaque conférence jusqu'à celle-là, on a en moyenne 140 participants pour chaque conférence. Et ceci à partir de 15 pays. Je pense que le virtuel a ouvert nos horizons vers d'autres pays, a ouvert notre coopération avec nos amis d'autres pays. Et oui, malgré tout ce qu'on est en train de passer au Liban, nous avons pu faire notre congrès. We did it. Malgré plusieurs fois qu'on l'a pu le tarder. Je veux remercier toute l'équipe technique qui était à un niveau durant ce congrès. Je veux remercier encore une fois Dr Marie-Louise Koussa pour ce congrès de très haute qualité et de pointe avec le choix des orateurs, des modérateurs et toute la précision qui a eu lieu et sans aucun problème durant toutes les 12 journées. Je vous demande de remplir les formes d'évaluation qui vous ont été envoyées par email et je vous demande de toujours rester branchés aux nouvelles de la Société de pneumologie. Nous allons continuer avec nos journées scientifiques et d'éducation médicale continue. Le virtuel nous facilite notre vie, malgré, je répète, tous les obstacles auxquels nous sommes en train de faire face. Et je vous encourage, mes collègues libanais, de participer au registre qu'on est en train de construire. Nous voulons que notre société soit de plus en plus forte, qu'elle ait une place dans la géographie épidémiologique des maladies pulmonaires et en mettant nos mains ensemble, nous pouvons faire évoluer notre société. Merci beaucoup encore une fois et bonne soirée.